Good afternoon. My name is Professor Nick Reed. I'm a consultant clinical oncologist based in Glasgow, and I'm going to talk to you today about the oncological treatments involved in the management of adrenocortical carcinoma. I'm going to divide it into two sections. The first is concentrating on adjuvant treatments, and then the second part is on advanced disease or patients who are diagnosed newly with stage 4. So we divide adjuvant treatments up because adjuvant treatment is usually given in a situation where the patient has had a successful operation but is deemed to be at higher risk of developing a recurrence. The types of treatments we use can be the drug Mitotane. There may be indications for using external beam radiotherapy, and increasingly there is discussion about combining Mitotane and cisplatin. There are also some people who believe that cisplatin and etoposide alone may be a good adjuvant. When it comes to patients with advanced disease, it's the same kind of drugs, Mitotane and conventional chemotherapy, but there are also a number of newer agents that are being investigated. Why do we need to consider giving adjuvant treatment? Well, the problem is that even in stage 1 disease, 82% of patients only 82% of patients will be cured. And in stage 2, 3, and 4, we can see from the slides that this gets progressively worse. Now, there are a number of factors that we can take into account when we try to decide on the need for adjuvant treatments. Well, there are a number of factors which help us to predict the likelihood of recurrence. For example, whether there's laparoscopic keyhole surgery or open surgery. We take into account the resection margin, in other words, the clearance around the tumor, a score called the proliferation index, which looks at the number of dividing cells and is divided into those where it's less than 10%, which is low, between 10 and 19%, intermediate, and greater than 20%, which is higher. And we can also use a score known as the Weiss score, which takes into account these criteria. There may also be some suggestion that patients secreting excess cortisol may have a worse prognosis. What is most exciting for the future is the use of molecular profiling and genomics, but this is still not mainstream. So just starting with the adjuvant treatment, Mitotane has become established as the drug of choice. And this will be used in the majority of patients with medium or high-risk disease. External radiotherapy is a little more controversial, but certainly there is good evidence from a number of retrospective studies to show that external radiotherapy can help to reduce the risk of localized recurrence. So the question is, do we use Mitotane alone or should we use it with chemotherapy? And this is another difficult and as yet unanswered question. So who gets it? Who do we give the adjuvant treatment to? How do we use it and when do we use it? Well, much of our information is based on the guidelines that came from the European Society of Endocrinology and ENSAT, the European Network for the Study of Adrenal Tumors. And 2 years ago, they published a very comprehensive and detailed analysis from an expert panel combining most of mainly European colleagues, but some North Americans, but mainly based in Europe. And these guidelines have been extremely valuable in helping us with our practice. So we can perhaps define patients where there's a definite indication for Mitotane, some with a possible benefit, and those where there's no benefit at all. So the definite indication really is the high-risk patients. The possible benefit would be for the intermediate-risk patients, and no benefit is for patients with very low-grade tumors. There are also debates about the duration of treatment, but generally the target is to try and keep a patient on Mitotane for 2 years. There are some centers that try and keep patients on it for longer. That's quite a challenge. There are important issues about how we monitor Mitotane. It's a drug that has now been shown that it is best to achieve certain target levels, and there is a facility to help us monitor that. It's a drug with a lot of side effects. Unfortunately, these can be quite distressing and unpleasant, and can include nausea, vomiting, muscular disorders, headaches, flashing lights. And generally, if a patient develops these side effects, one has to cut back the dose. And again, for younger patients, we have to bear in mind fertility issues, not just while on the drug, but for a while afterwards, as the drug is quite slow to clear from the body. And it may be another 6 to 12 months after completing treatment before fertility can be considered. So in this algorithm or schema that the European Society of Endocrinology and ENSAT developed, what we can see is that for patients with no residual disease, what we call R0, and who have a low proliferation index, where in other words, the number of dividing cells is low, we probably can get away with observation. Mitotane may be considered, but these are the ones where mitotane is probably of least value. When the Ki-67 is over 10%, then generally we would be looking at mitotane, perhaps with chemotherapy. But when we have patients who've got some form of residual tumor, and particularly when there's a higher proliferation index, then mitotane with localized radiotherapy to the adrenal bed will be considered. And then for this group here, where the Ki-67 is higher again, this is where we may throw the book at patients, as it were, by using mitotane, perhaps with chemotherapy and radiotherapy. For patients who've got more residual disease, more extensive residual disease, these really need to be approached in a different manner. This is just another way of looking at this, and really it's just to sort of, again, perhaps rephrasing it, saying that we would consider mitotane rather than always give mitotane in this group. We would discuss it with the patient, whereas in the intermediate high risk group, adjuvant mitotane will be strongly recommended. And in patients who've got some residual disease or have other high-risk factors, mitotane will be used. What about the evidence in favor of it? Well, this is a busy slide, and please don't try and look at everything on here. All we're trying to do is to highlight that in the patients who got mitotane, as opposed to those who didn't have mitotane, there was a much higher relapse rate. And this is, again, will be highlighted in another slide, in fact, on this next slide, showing that this is what is looking at the shift to the left, where these boxes to the left indicate that the treatment with mitotane led to a more favorable outcome compared to those patients who didn't receive it. And this triangular box here, because it shifted to the left, does achieve statistical significance and indicates that there is a favorable benefit. As you can see, some of these cross over, and this is what's known as the confidence limit, but nevertheless, the fact that this little box here is to the left indicates the benefit. And it's the same with, unfortunately, some patients will die from their disease, but there is a reduced risk of dying from your disease if you have mitotane. What dose to use? Now, this has changed of late, and there have been many ideas and ways of trying to do this. In the past, one used to build up the dose slowly till you got to tolerance and toxicity. And there was a Dutch study a few years ago that suggests giving a fixed dose of 2 grams. But now the evidence seems to be that we build up the dose quickly, but we use the monitoring service, the pharmacokinetics or dose drug measurement, measuring the drug level in the body from HRA, to try and target in the range 14 to 20 milligrams per liter. And this works very well. I've already commented on the side effects, and it can be an unpleasant drug, particularly when patients reach toxic levels. But if it's especially with a team familiar with managing the drug, it should be possible to keep these side effects to a manageable level. Clinical trials have been very few and far between in this field, and the ADUVO study, the first of the ADUVO studies, is due to finally complete the data collection later this year, and hopefully that will give us more information. And I've already referred to the ESC ENSAT guidelines. In terms of where we go forward, the ADUVO 2 is looking at high-risk patients. I should have said that in the in the first ADUVO study, it's mitotane versus observation. But this is looking at mitotane versus cisplatin and etoposide chemotherapy in patients with a higher Ki-67, with more and with stage 1 to 3 disease, and it is a registration study. And perhaps the other, we'll come to this shortly, but the other big direction for the future is molecular profiling or genomics. And this is just summarizing the ADUVO, we can skip that. So let's move on to the unfortunate case where the patient has developed a recurrence of the tumor, or unfortunately the surgeon is unable to remove the tumor. And this is an example of a patient who presented to us a few years ago, where there is a large mass in the adrenal gland, which was clearly beyond any ability to remove it. What are the options? Well, obviously we will discuss surgery whenever it's possible, and this should be run through the MDT, the multidisciplinary team, and wherever possible we will operate. But otherwise, it's the same drug, Mitotane, that appears, and conventional first-line chemotherapy. But beyond that, there are no firm, established, or licensed drugs. There are various ablative procedures, which I will discuss very briefly at the end. So it's still Mitotane that tends to be our first choice. And we will use the drug on its own if there's a prolonged interval between the surgery and the development of the recurrent tumor. But if it's a short interval, then probably we will want to combine Mitotane with chemotherapy. And the three chemotherapy drugs that are most used are known as EDP, the E standing for etoposide, the D for doxorubicin, and the P is for platin, although its proper name is cisplatin, but you will hear it called EDP. There was a previous combination with streptozotocin and Mitotane, and this was compared in the Firm Act clinical trial, but was shown to be inferior to the EDP regime. Response rates, in other words, patients who benefit and have a shrinkage of the tumor, generally are around 30 to 40%, but quite often those responses may be relatively short. But there will be some patients who have prolonged and significant benefits. And this is a brief summary from the ENSAT from 2 years ago, looking at the options of no previous treatment, consider Mitotane and locally ablative treatments. If it's more higher risk, then the Mitotane and EDP. Whereas if there's a recurrence during Mitotane or it's a very short interval, then you need to look at chemotherapy up front. So what do we do if the patient unfortunately progresses, has a progression of the tumor while on Mitotane? Then we would move to the EDP regime. But if the patient has already had EDP, then we are somewhat limited. And there are combinations such as capecitabine and gemcitabine, known as CAP-GEM or GEM-CAP, TKIs, tyrosine kinase inhibitors, other targeted agents, and we will talk briefly about the insulin-like growth factors, immunotherapy, which has generated a lot of interest, cell cycle inhibition drugs, and if there are available, phase 1 and 2 clinical trials should always be considered. Again, this is a slide, not wishing you to look at everything on the table here, but essentially this is just showing the number of drugs on the number of agents that have been used. And this box on the right is trying to show the green where patients had what's called a complete response or complete disappearance of tumor. The gray is where patients had the gray is where patients had stable disease, and the orange is patients who had a partial response. And you can see that, disappointingly, there's lots of red and gray in here, indicating that our treatments are not that effective. But there are drugs like gemcitabine, capecitabine, EDP, and Mitotane, which do tend to stand out. So from the ENSAT guideline, what they suggested is that consider enrolling a patient into a clinical trial, consider local regional treatments, what we call ablative treatments, but they did suggest that the gemcitabine and capecitabine combination is worth considering. And whether you stop Mitotane should be discussed on an individual basis. I think, although they've included streptozotocin Mitotane combination, it's a pretty nasty combination of doubtful benefit, and I must admit I would be looking at alternatives. Just to sort of show that there really have been very few clinical studies or trials, but there was one multicentric European study that showed about 30% of patients had some form of benefit, either in terms of stable disease or response. An Italian series of only 28 patients showed one achieving a complete response, one with a partial response, and 11 had stable disease, which is actually pretty good considering these were heavily pretreated patients. And admittedly, at the short interval at 4 months, but 46% had not shown any progressive disease. And a very similar figure came from Henning's group, which was an international multi-center study, where there was around a 30% response rate. Also, of the conventional agents, I highlight a drug called temozolomide, 28 patients again, with 1 complete response, 5 partial response, and 4 stable disease. Now, the reason I highlight this is that this is an interesting drug, used initially in brain tumors and has recently developed a lot of interest in other neuroendocrine tumors. But those patients who had the MGMT deficiency seemed to do better. And the other interesting thing is that there was something known as homologous repair deficiency, HRD. There was a potential role there. And this is similar to the drugs that are used in breast cancer and ovarian cancer, known as the PARP inhibitors. And there may be some synergistic or complementary effect between temozolomide and the PARP inhibitors. Bottom line here is that these numbers are small, they're generally rather low response rates, and unfortunately tend to be of short duration. So there's no licensed or approved drugs beyond that, and very limited clinical data. But the tyrosine kinase inhibitors, like sunitinib, have been used with limited benefit, insulin-like growth factor, the PD-L1 inhibitors, and cell cycle inhibition. We'll just briefly go through these. And this is just to show some recent examples. This is from the clinical trials website from the US. Most of these, as you will see, either a mitotane or these PD-L1 inhibitors, pembrolizumab, nivolumab, ipilimumab, pembro again, and nivo-ipi combination. And another interesting one that appears in here is cabozantinib, which is a multiple tyrosine kinase inhibitor, which has shown potential activity in medullary thyroid cancer and other neuroendocrine tumors. But I guess what we want to do is to move forward, and probably the most exciting thing is molecular profiling. And the Cancer Genome Atlas, the TCGA, did specifically include a number of patients with adrenal cancers. And they identified 3 subgroups. The question is, are these clinically useful? And I think the jury is still out. So if we look at this slide, and there's a very similar slide I'm going to show in a moment, you can see here they identified groups COC1, COC2, and COC3. And this is the number of patients showing the survival. And you can see a very clear difference between these. But, and we can also see that there are some differences in the molecular profiling. So this all looks very promising if you happen to be in the green line, as it were. If you're a COC1 patient, that looks more promising. And this is a more recent paper that they published last year, again indicating that we've got COC1, COC2, and COC3. So rather traffic lights, green, amber, and red. And the green ones do well. The orangey ones, amber ones, tend to do intermediately. And the patients with the fall into group 3, they've written they do dismally, which is very disappointing. But we can see there are some differences. Now, what these really mean is still unclear. And this beta-catenin WNT profiling may be of relevance, and this business here about cell cycle inhibition. But as yet, it's not proven that these are the way forward. They are very much under investigation. There was a great deal of excitement a few years ago when it was demonstrated that this insulin-like growth factor, IGF-2 expression, and the insulin IGF-1 receptor could be of potential value. Because 90% of patients have a loss of heterozygosity of the IGF-2 locus. And 3 drugs were investigated, but sadly, only a small number responded, less than 20%. And the question has not been answered, but do these happen to be the ones that match the COC1 group? Because if that was the case, then at least you might be able to use that in patients and you could show that had the COC1 features. The COC2 and COC3 are more aggressive, and you can show that 40% have signaling activation of something known as the beta-catenin and the WNT signaling pathway. But as yet, there's no proven drug target that's become available, though I do believe that AstraZeneca have a drug under development which targets the WNT pathway, but I'm not aware of anybody using it in adrenocortical cancers. Cell cycle inhibition is an important new class of drugs which has generated a lot of interest in breast cancer. And I hadn't appreciated till I prepared this talk that the conventional agents, etoposide, gemcitabine, capecitabine 5-FU, may actually hit the cell cycle inhibition. It's an obvious thing when you think about it, but I hadn't thought about it in that way before. And that's perhaps why they have established themselves as three of the most useful drugs in this condition. But there are newer agents, specifically the cell cycle inhibitors targeting tyrosine kinases and the CDK4/6. So there are drugs like palbociclib and ribociclib, but again, they're not yet involved in being investigated in routine practice. They're perhaps more likely to work in the COC3 group, which have the greatest proliferation and activity. And I've already touched upon the homologous repair deficiency and the potential for PARP inhibitors, including temozolomide. This is generating the most excitement at the moment, the immunotherapy. These tumors are largely immune poor, and about 30% of ACC have silencing of the mismatch repair genes, and therefore they may be part of Lynch syndrome. And clearly it's been shown that there's a potential use here. Certainly these drugs work in colorectal cancer patients and in endometrial cancers with mismatch repair. And pembrolizumab, ipilimumab, nivolumab, and combinations are being investigated, but not yet established. There's no firm evidence as yet. So where do we go forward? Requirement really for an established network for molecular profiling. And NHS England is establishing 7 genomics hubs. The Scottish Health Service Genetics Consortium also had a recent strategy meeting on how to take this forward. But these are rare tumors. And we have a catch-22 situation that we need genomics, but at the same time, we need to have candidate drugs. And it's matching those two that's going to be one of the biggest challenges. But also funding, making sure that patients with ACC get into this. I said also there were other options, and external radiotherapy has a potential role for bone metastases and other metastatic tumors. Radiofrequency ablation, microwave, embolization all have a potential role, and bisphosphonates for patients with tumors in the bones. So in conclusion, these are rare tumors which sadly have quite a high relapse rate, particularly beyond stage 1. Mitotane and EDP are used as the principal drugs at present, but there are limited options when we get beyond that. Capecitabine, gemcitabine perhaps being the key ones. There's a huge role, potential role for genomics and profiling, but we need new and better agents. We need teams to work together, and that way hopefully we'll be able to improve our outcomes. And we need to try and get more clinical trials because there are still very few that specifically target adrenocortical tumors. So I thank you all for your attention and hope that I haven't bamboozled you too much with the science. And if I was with you present, I would be able to take questions, but sadly, this is not where I am. I'm stuck in Bearsden in Glasgow rather than Loch Awe. Thank you for your attention.